Thank you, Professor Weidman, and thank the organizing committee for inviting us to come and present this material to this very esteemed audience. I'd like to thank the Chemlog Foundation also for the invitation to present some of the research that we were involved with. The challenge of my lecture this morning was to discuss with you the use of tilted implants in oral rehabilitation. And I think that it's an excellent subject because it has a great bearing on what we're doing today, but not only today, but what we've been doing for the last 30 years with implant dentistry. Implant prosthodontics is, let's make this work. Okay. This is not working. The advancer. The first slide is to discuss the concept of using tilted implants, but since you're not going to see that slide unless the technology can move the slides forward. Hello? Well, I don't have any balls to put in my mouth. I actually did that. It was a great opening show, wasn't it? The material that we are going to be discussing once the technology works is going to be the consideration of everything that we do with implants is prosthetically driven. I'm sure that your patients are no different than the patients we have in the United States who are coming to us. They're not looking to put screws into their bone. They're coming because they want teeth. So everything that we do is prosthetically driven. And the concept that we use in our center is one of minimally invasive, minimally intrusive, minimum treatment times. How quickly can we get the patient through with evidence-based protocols that will provide them with long-lasting results? We still don't have the advancing. Can you manually advance the slide? Yeah. Okay. The first part of the lecture was going to discuss some of the historic literature. In 2000, Bo Rangberg and colleagues in Sweden did a study on 47 patients where they evaluated the use of tilted implants. And in that study of 47 patients, they looked at various parameters of implant position, implant location in the anatomy, the gender was evaluated, and what they found as an end result was that the tilted implants, implants that went into the pterygomaxillary area, implants that went into the region just anterior to the sinus, had about an equal success rate with those implants that were placed axially, along with what we would consider the traditional long axis implant placement. Any assistance with the moving slides forward? Well, we went from that study in 2000 to another collaboration that Bo Rangberg, who is a biomedical engineer, worked with Paulo Malo on the concept of using tilted implants successfully, but reducing the number. You know, when we began with the Brandmark system back in the early 1980s, it was not uncommon for us to use 10 implants in the maxilla and 8 implants in the mandible. And toward the end of the 1980s, we began to reduce that to 8 implants in the maxilla and 6 implants in the mandible. And then through the 90s, we reduced that further to 6 implants in the maxilla and 5 implants in the mandible. And the reduction has continued. I don't know whether we'll be able to get to the point where we can do a complete mouth rehabilitation on 1 implant, but we're getting closer to that. and we'll be discussing, hopefully discussing the all-on-4 concept using tilted implants. In this past year, the Journal of the American College of Prosthodontists published a research paper that we did in our center, where we evaluated 800 Brennemark implants using the all-on-4 protocol. So the 800 implants were applied to 200 jaws. And the outcome of that study provided us with some very basic scientific information. We looked at the location of the implants, tilted implants in the posterior, axially inclined implants in the anterior. We looked at gender, male and female. We looked at a number of other parameters, but these were the major ones. And we looked at the success rates. And what was interesting, when we evaluated the maxilla versus the mandible, there was only a 1% difference between the maxilla and the mandible, which was not statistically significant. So the cumulative success rate for the implants was about 97.5%. When we looked at gender, male versus female, again, the difference was only 1% difference, and it was not statistically significant. And when we finally got to evaluating the difference between the axially positioned implants in the anterior and the angulated implants in the posterior, is it working? Oh.
There is a problem, I would say, that the speak a bit